Assalamualaikum and hi everyone. We are from Group 4 would like to present a group project for MRD 446. The topic that we are choosing is knee. This is our group members, consists of 4 starting with Nazir Razmi, followed by Arif Ermizi, Muhammad Hafiz and Muhammad Najwan. Hi, my name is Nazir. I will start the presentations with the introductions and overview of the knee. As we know that the knee is a complex hinge joint connecting the thigh bone, which is the femur, to the shin bone or tibia. Femur is the strongest and longest bone in the human body, whereas tibia is the primary weight-bearing bone of the lower leg. The knee joint is surrounded by a synovial capsule which produces lubricating fluid, and it's supported by the ligaments, tendons, and cartilage which enabling bending and strengthening motions. Let's move to the anatomy of the knee. The knee is made up by 8 main parts. Through this presentation, I will explain the parts of the knee regarding its structure, some characteristic functions, and biomechanics. Let's go through one by one, starting with the bones. 3 bones meet to form knee joint, including femur, tibia, and patella. Why fibula was not stated as a part of the knee? From Ranger 2014 mentions about the proximal fibula is not part of the knee joint because it does not articulate with any aspect of the femur. The patella, which is the largest systemic bone in the body, is a flat triangular bone about 2 inches in size. It appears to be upside down because its point apex in the inferior border and its base at the superior border. The patella serves to protect the anterior aspect of the knee joint and assist in movement. The knee joint consists of 2 main parts as articulating surface. Tibiofemoral joint is located between medial and lateral femoral condyle, articulates with the tibial condyles. It is the weight-bearing component of the knee joint and best view in AP projections. Patellofemoral joint is anterior aspect of the distal femur, articulates with the patella, and this joint is susceptible to the largest load in the body and high risk for injury. It is best viewed in lateral or scalene projections. There are 3 types of cartilage, including elastic, fibrocartilage, and hyaline cartilage. Hyaline cartilage is the most common type of cartilage because it is smooth and shiny. That's why it covers the knee bones, which minimize frictions of movement. While cartilage reduces frictions between bones, bursae also reduce frictions between bone and soft tissue such as muscles and tendons. A bursae is a tiny and fluid-filled sac located between a bone and soft tissue. The tendons connecting the knee bones to the muscle, for example, quadriceps tendons connecting the muscle in the front of your thigh, whereas patellar tendons used to stretch knee bone to the tibia. The knee is supported by the ligaments which connect bones to bones. The collateral ligament consists of 2, medial or MCL, and lateral collateral ligaments or LCL are located at the periphery and outside of the capsule of the knee joints. It prevents adductions and abductions of the knee movement. The cruciate ligament consists of anterior or ACL and posterior cruciate ligaments or PCL, which are cross each other as they attach to the intracondylar eminence of the tibia. ACL runs from the anterior tibia to the posterior femur, while PCL runs from the posterior tibia to anterior femur. PCL is larger and stronger than ACL, therefore is less common injury than ACL. The medial and lateral menisci are C-shaped fibrocartilage rings, and medial menisci attached with MCL, while lateral menisci attached with PCL. Meniscus act as shock absorber to reduce dome of direct impact and stress occurring. Medial meniscus is more common injury and associated with the ACL tears. The muscle must be strong to provide adequate support to the knee. Quadriceps muscle located in the front of the thigh, and it comprised by the hamstring at the back of the thigh. For the lower leg muscles, the gastrocnemius placed at the back. Now, turning to the next main point is about the biomechanics of the knee. The knee joint supports body weight, absorbs shock, and assists lower limb swing during daily motions. For example, in walking, The knee absorbs and distributes forces as the leg moves forward. During running, the knee increases loads due to higher speed with the quadricep and hamstring muscle playing crucial roles. Jumping places sudden intense force to the knee, requiring efficient shock absorptions. Biomechanically, the knee acts as a hinge joint, allowing flexion and extension, and also has some gliding and rotational capabilities. The knee joint divides into two types of motions. The primary motion as the main movement like flexions or bending knee and extension or straighten knee. Flexion produced by the hamstring muscle and extension produced by the quadricep femoris muscles. The medial and lateral motions permit a small degree of rotations, medial below 30 degrees and lateral rotations below 40 degrees. Secondary motions, including anteroposterior displacement of femur or tibia, shows the importance of ligament as ACL prevents femur from sliding backward on the tibia, and PCL prevents the femur from sliding forward on the tibia. Abductions and adductions through valgus and varus force show that MCL resists valgus stress force, especially in the extended knee, and ACL resists varus stress force across the knee. Severe knee injuries like ligament tears, meniscal damage, and cartilage tear can disrupt the knee stability and mobility. That's why understanding this biomechanics is vital for injury preventions and effective treatment.
Hello everyone, my name is Arif Emizi bin Arifin and I will continue the presentation. We are going to explore the anatomy of the knee joint, focusing on the structural components and their specific attachment. In the second part of my presentation, we will discuss about the function of the knee parts. The knee joint involves three main bones. The femur articulates with tibia and the patella. The tibia is the primary weight-bearing bone of the lower leg and articulates with the femur and fibula. Patella articulates with the femur to form the patellofemoral joint. The medial facet of the patella articulates with the medial condyle of the femur, and the lateral facets articulate with the lateral condyle of the femur. The articular cartilage covers the distal end of the femur, proximal end of the tibia, and posterior of the patella. Additionally, the medial and lateral menisci attached to the medial and lateral tibial plateaus provide further stability and shock absorption. The anterior cruciate ligament (ACL) originates from the posterior aspect of the lateral femoral condyle and insert into the anterior intercondylar area of the tibia. Conversely, the posterior cruciate ligament (PCL) starts from the anterior part of the medial femoral condyle to insert into the posterior intercondylar area of the tibia. Then we have medial collateral ligament (MCL), originates from the medial epicondyle of the femur and insert into the medial aspect of the tibia, and lateral collateral ligament LCL originate from the lateral epicondyle of the femur and insert into the head of the fibula. The quadricep tendon originates from the quadricep muscles group and insert into the patella, continuing as the patella tendon, which then extend to attach at the tibial tuberosity on the tibia. Quadricep groups originate from the various parts of the femur and insert through the quadricep tendon into the patella. Hamstring muscles group originate from the ischial tuberosity except for the short head of the bicep femoris, which originate from the femur and insert on the tibia and the fibula. Popliteus originates from the lateral femoral condyle and insert on the posterior tibia. Gastrocnemius muscle originates from the two heads, with the middle head originating from the popliteal surface of the femoral shaft and the posterior surface of the medial femoral condyle. Synovial membrane surrounds the entire inner surface of the knee joints, encapsulating the femoral condyle, tibial plateau, and patella. Bursae strategically placed around the knee to reduce friction, primarily found near the patella, under the tendon attachment, and around muscles. We continue to the second part of my presentation, and we will look how the parts assigned are well suited to perform the function that they do. Femur, tibia, patella, and fibula provide structural support and leverage necessary for movement, bear body weight, and facilitate articulation at the knee joint. Articular cartilage covers the ends of the femur and tibia, as well as the back of the patella, providing a smooth, lubricated surface for low friction movement within the joint. menisci medial and lateral meniscus act as shock absorber, distribute loads across the knee, enhance joint stability, and aid in joint lubrication and nutrition. Anterior cruciate ligaments prevents the tibia from sliding out in front of the femur and provide rotationally stability. Posterior cruciate ligaments prevents the tibia from sliding backward under the femur. Medial collateral ligaments provide stability against valgus forces, which prevents the knee from caving inward. Lateral cruciate ligaments provide stability against varus forces, which prevents the knee from bowing outward. Meniscofemoral ligaments stabilize the posterior horn of the lateral meniscus and connect it into the femur. Quadriceps tendons connects the quadriceps muscles group to the patella, playing a key role in knee extension. Patella tendons continues from the quadriceps tendons, attaching the patella to the tibial tuberosity and facilitating knee extension. Hamstring tendon, bicep femoris, semitendinosus, semimembranosus facilitate knee flexion and internal and external rotation of the tibia. Popliteus tendon unlocks the knee from a fully extended position and assists in knee flexion. Gastrocnemius tendon, part of the Achilles tendon, influences knee flexion and ankle plantar flexion. Quadriceps groups, which vastus lateralis, vastus medialis, vastus intermedius, rectus femoris, are primarily responsible for knee extension. Hamstrings group, bicep femoris, semitendinosus, semimembranosus, primarily responsible for knee flexion and support tibial rotation. Popliteus unlock the knee and assist in flexion. Gastrocnemius assist in knee flexion. Synovium produce synovial fluid, which lubricates and nourish the interior of the knee joint. Busae small fluid fill sacs such as prepatella, infrapatella, suprapatella, busae that reduce friction and cushion pressure points between the bones, tendon, and muscle near the joint. That's all for my presentation. Thank you.
Assalamualaikum everyone. My name is Muhammad Hafiz bin Roslan. Today, I will present about physiology of the knee function and involvement of the joint, tendon, and cartilage in knee flexion and extension. Knee physiology. Stated by Marco et al. In 2023, the knee is the biggest joint in the body and it is essential for both movement and stability. Today, we will explore its amazing structure. Bones. The knee comprises three bones, the femur, tibia, and patella. Together, they provide the framework for our knee joint. Ligament. Key to stability, ligament like the ACL, PCL, MCL, and LCL connect this bone, preventing excessive movement and supporting the joint during activities. Cartilage. Articular cartilage cover the ends of bone, reducing friction during movement, while the meniscus act as shock absorbers, enhancing joint stability and distributing force evenly. Muscle. Our knee movers and shakers include the quadriceps and hamstring. These major muscle groups are responsible for both movement and stability, working in harmony to support various activities. Muscle involvement in knee function. Quadriceps and hamstring. The quadriceps locate at the front of the thigh, extend the knee, while the hamstring at the back flex it. Together, they ensure smooth and controlled movement, providing stability during activities, supporting muscle. Additionally, muscle in the calf, such as the gastrocnemius, and muscle in the hip, like the gluteus maximus, also play crucial roles in knee function. They assist in maintaining balance, stability, and control, contributing to overall joint health. Stated by Karadash in 2021, flexion of the knee. Flexion is the bending of the knee joint. which bring the calf closer to the thigh. Important, the flexion is the fundamental movement that allow us to perform activities such as sitting, squatting, and climbing stairs with ease. It also helps in absorbing shock during activities like running and jumping, reducing stress on the knee joint. Extension definition. Stated by Taradash in 2031, extension refers to strengthening of the knee joint, returning the leg to its anatomical position. Extension is crucial for action like standing, walking, and running, providing stability and support during weight-bearing activities. It also ensures proper alignment of the lower limb, optimizing biomechanical efficiency and reducing the risk of injury during dynamic movement. For the next slide, we'll dive into the essential roles of tendon, cartilage, and ligament in knee flexion and extension, two fundamental movements crucial for daily activities. Flexion, stated by Farhan Jones 2023. During knee flexion, the patellar tendon and quadricep tendon work together to facilitate smooth movement, while articular cartilage and meniscus absorb shock and enhance stability. Ligament, like the ACL and PCL, prevent excessive movement, maintaining joint integrity. For the extension, stated by Farhan Horst Jones 2023, extension, as the knee extends, the patellar tendon and quadricep tendon aid in the strengthening of the knee joint. Articular cartilage continues to provide smooth movement, and ligament, such as the ACL and PCL, ensure stability during extension. So everyone, that's all for my presentation. Thank you.
Assalamualaikum. My name is Muhammad Najwa Becher Hashim. We explain and explore the projection technique and the anatomical structure seen in both standard AP and lateral knee projection. In this AP view, we can clearly see several key anatomical structures. The bone include the patella, femur, tibia, and the lateral aspect of the fibula. Additionally, the tendons such as the quadricep tendon attaching superiorly to the patella and the patellar tendon attaching inferiorly to the tibia are well defined. Moreover, the ligaments such as the ACL and PCL are visible along with soft tissue like the joint space, cartilage, and the surrounding muscle. Now, let's explore the lateral knee projection. In this lateral view, we can observe the femur, tibia, and the prominent fibula along with portion of the patella. Tendons such as the patellar tendon and the quadricep tendon, depending on the angle of flexion, as well as the bicep femoris tendon and popliteus tendon are also visible. Moreover, the ligament including the fibula collateral ligament and the popliteofibular ligament are clearly present. Soft tissue such as the lateral meniscus, lateral joint space, and the muscle and tendon on the lateral side are also visible in this projection. For the next slide, we will explore of the intricate anatomy of the knee bone. Let's start with the AP view of the knee bone. Here, we can identify several key structures. Femur, the upper bone of the knee joint. Patella, centrally located in the knee joint. Medial and lateral condyles, the rounded prominence on the inner and outer side of the distal femur. Medial and lateral epicondyle, a bony projection on the inner and outer side of the distal femur. Intercondyle fossa, the hollow depression between the condyle of the femur. Tibia and fibula, the larger and smaller lower leg bone. Medial and lateral tubercle, a small bony prominence on the inner and outer aspect of the tibia. Intercondylar eminence, a raised area between the tibia condyle. Tibial tuberosity, the bony prominence on the anterior surface of the tibia. Now, let's examine the lateral view of the knee bone, which provides a different perspective. Femur, the upper part of the knee joint. Patella, situated in front of the knee joint. Medial and lateral condyle, the rounded prominence on the inner and outer side of the distal femur. Medial and lateral epicondyle, a bony projection on the inner and outer side of the distal femur. Posterior intercondyle area, the space between the condyle at the back of the knee joint. Anterior intercondyle area, the space between the condyle at the front of the knee joint. Tibia and fibula, the larger and the smaller bone of lower leg bone. Tibial tuberosity, a bony prominence on the anterior surface of the tibia. Next, let's dive into the intricate network of the tendons surrounding the knee joint. From the AP view, we can see quadriceps tendon that attach superiorly to the base of the patella and continue as the patellar ligament to the tibial tuberosity. Patellar tendon that extend from the inferior pole of the patella to the tibial tuberosity. Iliotibial band that attach proximally to the iliac crest and distally to the tubercle on the lateral tibia. Popliteus tendon that attach proximally to the lateral femoral condyle and distally to the posterior aspect of the tibia. Gastrocnemius tendon that attach proximally to the femoral condyle and distally to the calcaneus via the Achilles tendon. Now, let's examine the lateral view of the knee joint and its associated tendon. Quadriceps tendon that attach superiorly to the base of the patella and continues as the patellar ligament to the tibial tuberosity. Hamstring tendon divided by two, which is bicep femoris attached to the head of the fibula, semitendinous and semimembranous that attach to the medial aspect of the tibia. Sartorius tendon that attach proximally to the ASIS and distally to the medial aspect of the tibia. Gracilis tendon that attach proximally to the SP and distally to the medial aspect of the tibia. And also, we delve into the intricate network of ligament. Let's start with the SCL. Running diagonally in the middle of the knee, the SCL attach from the posterior aspect of the femur to the anterior aspect of the tibia. Moving on the PCL, located behind the SCL, the PCL attach from the posterior aspect of the femur to the anterior aspect of the tibia. Next, we have the MCL and its counterpart, the LCL. The MCL attach from the medial epicondyle of the femur to the medial condyle and proximally shaft of the tibia. The LCL attach from the lateral epicondyle of the femur to the head of the fibula. The patellar ligament connecting the inferior pole of the patella to the tibial tuberosity assists in knee extension, while the medial and lateral patellofemoral ligament stabilize the patella, preventing dislocation. The oblique popliteal ligament, part of the arcuate ligament complex, reinforces the back of the knee joint, while the transverse ligament aids in stabilizing the medial meniscus. That's all for today. Our team has provided you a QR code for you to have the access for this video presentation. Feel free to scan it below. Thank you.